today I'll be discussing about the topic chordal preservation and mitral valve replacement. I'll be covering my talk under the following subheadings: Introduction, Anatomy, Physiology, Effects of chordal transection, Physiological alteration in mitral valve surgery, and Techniques of chordal preservation. Coming out of the introduction, the aim of mitral valve surgery is to provide a competent non-obstructed valve without compromising the left ventricular function. It can be usually met with surgeries like mitral valve repair. However, in our subset of patients, where we encounter a large number of patients with rheumatic, heavily calcified mitral valve stenosis, repair is not feasible. So in this subgroup of patients, mitral valve replacement is the only option. Coming on to the anatomy, mitral valve is a bicuspid valve with a subvalvular apparatus comprising of the chordae and the papillary muscles. In normal heart, the mitral valve annulus is round in diastole, ellipsoidal, and systole. In systole, the mitral valve orifice decreases by almost 25%, while the circumference of the mitral valve annulus reduces by 30%. As can be seen in this diagram, there are two groups of papillary muscles, the anterolateral and the posteromedial papillary muscles, and each of these gives rise to chordae to both the anterior as well as the posterior mitral valve leaflets. There are three types of chordae: the primary or the marginal chordae. They insert on the free margin of the leaflets, as can be seen in this diagram, where the primary chordae can be seen on the free margin of the leaflets. The secondary or the strut chordae insert on the rugged ventricular surface of the leaflets, while the tertiary or the basal chordae, they are limited to the posterior leaflet only, and they connect the basal part of the posterior leaflet directly to the ventricular wall. As can be seen in this diagram, the primary, secondary, and the tertiary chordae inserting onto the anterior and the posterior leaflets. Coming out of the physiology, in 1922, Wiggers and Katz proposed the concept of annular ventricular continuity. The left ventricular geometry and function is a dynamic interaction between the mitral valve annulus and the left ventricular wall. Attachments between the mitral valve annulus and the left ventricular wall moderate the LV distension during diastole and wall tension during systole. When the papillary muscles contract during the isometric phase of the cardiac cycle, the closed mitral valve is drawn into the LV cavity, thus reducing the longitudinal axis of the left ventricle and increasing its short axis. As a result of this, the myocardial fibers stretch additionally and generate more tension, leading to greater contraction and an increase in stroke volume. During systole, the ventricle undergoes counterclockwise torsional deformation of the apex with respect to the base, and during isometric relaxation and in early diastole, this is reversed, known as diastolic recoil. Disruption of the papillary annular continuity impairs this torsional deformation, thereby causing abnormal diastolic function and disruption of the normal LV stress strain patterns. Coming out of the brief history, in 1964, Lilly proposed the concept of chordal preservation during mitral valve replacement to encounter the problem of post-operative low cardiac output in these patients. However, there emerged a strong opposition to his ideas. The concept was reintroduced by David in 1981 after an experimental study of mitral valve replacement in dogs. This study showed that the left ventricular function deteriorated if the chordae were transected but remained unchanged when the chordae were intact. They also demonstrated that increased LV end diastolic pressures after chordal transection and conventional MVR, whereas these pressures decreased after MVR with chordal preservation. The effects of chordal transection, Hansen et al. Demonstrated that transection of the chordae to the anterior mitral leaflet reduced the LV function to a greater degree as compared to the transection of chordae to the posterior mitral leaflet. He hypothesized that preservation of the subvalvular apparatus improved the LV systolic performance by reduction of the LV afterload. Chordal transection shortened the long axis of the left ventricle and caused dilatation of the chambers. In chronic MR, in chronic mitral regurgitation, the LV function gradually declines. The regurgitation into the left atrium during systole is added to the forward stroke volume and tends to increase the total forward output and the ejection fraction in the early phase. However, a progressive dilatation of the LV increases the wall tension as per the Laplace law, which leads to increased wall stress and also increases the afterload. So after mitral valve replacement, there is a rapid increase in the LV afterload, and the adaptation of the LV to this change depends on the annuloventricular continuity. Fixation of the mitral valve annulus with the rigid prosthesis interferes with the distension and contraction of the baroconstrictors. However, in patients undergoing surgery for mitral stenosis, the LV is already small, and because of the severe subvalvular fusion and often fused, rigid, and calcified leaflets, the annulus loses its sphincter-like function. So excision of this valve with chordae does not produce the picture of reduced preload and increased afterload as observed after mitral valve replacement for chronic mitral regurgitation. Nevertheless, the loss of annuloventricular continuity still leads to progressive LV dilatation with eventual decline of the LV function in the long term. Now, coming on to the techniques of chordal preservation, there are various techniques that have been described. So, I'll be covering all the major techniques in brief. First, coming on to the PML preservation, this was described by Lilly. So, the posterior mitral leaflet is bound to the annulus with a running stitch. This was one of the first techniques that was introduced for chordal preservation, where he preserved the posterior mitral leaflet along with its chordae. So, Lilly reported a reduction in the operative mortality from 37% to 14%. That was a drastic decline in mortality with preservation of the posterior leaflet. Then came the David's technique. So, in this technique, the AML is incised at its base 2 to 3 mm from its attachment. So, as can be seen in this diagram, the incision is carried to both the sides and brought down centrally towards the free edge of the leaflet, such that a triangular segment of the AML is thus excised, leaving the chordae attached to the remaining part of the leaflet. So, the remaining part of the AML is then resuspended to the mitral valve annulus by sutures used to secure the prosthetic valve. The PML with its chordae is left intact in this technique. So, the advantages of this procedure are that there is maintenance of the chordae in the natural anatomical orientation. There is a reduced risk of left ventricular outflow tract obstruction, and there is a reduction in the bulk of the leaflet tissue, since we have excised that triangular segment of the AML. Coming on to the third technique, the Ficke's technique. In this technique, the AML is split from the center of the free edge towards the annulus. As can be seen in this diagram, the incisions are then made on either side of the split towards the two commissures to detach the AML from the annulus. The resulting two halves of the leaflet, along with the intact chordae, are trimmed to remove the thickened and calcific areas of the leaflet, and then rotated posteriorly and sutured to the posterior mitral annulus. So, the advantages of this technique, that this technique has been reported to be specifically useful while implanting tilting disc prostheses. Currently we are using bi-leaflet prostheses. So, this technique was specifically useful while implanting the tilting disc prostheses, where disc entrapment by the subvalvular apparatus was a concern. Also, the chordal continuity to the AML is well maintained in these cases. The disadvantage of this procedure is that it disturbs the normal geometric relationships of the mitral subvalvular apparatus, which could alter the distribution of the regional left ventricular wall stresses and disturb the chordal tension during papillary muscle contraction, thereby reducing the global LV systolic and diastolic functions. Coming on to the fourth technique, the Khonsari's technique. The AML is detached from the annulus between the two commissures, and an ellipse of tissue is excised, and the rim of the leaflet tissue containing the chordae is reattached to the anterior annulus. This is a Khonsari 1 technique, as can be seen in the diagram part A. However, if the leaflet is thick or calcific, it is divided into 2 to 5 chordal segments, which are then reattached to the annulus, the Khonsari 2 technique. Multiple segments of the AML with the chordae are then attached to the annulus. The PML is retained completely, and the redundant leaflet tissue is folded up into the annulus by passing the valve sutures through the annulus and bringing them through the leading edge of the leaflet tissue, thereby buttressing the sutures. So, the advantages of this procedure are there is no left ventricular outflow tract obstruction, there is no interference with the prosthetic valve function. Myocardial rupture is prevented by maintaining the tethering effect of the intact subvalvular apparatus. The disadvantages include the chordae could become stretched around the struts of the bioprosthesis, thereby exerting more stresses on the retained chordae. Coming on to the fifth, the Mickey's technique. It is the most commonly used technique. It maintains the normal chordal tension as the direction of the chordal force is more anterior than the Ficke's technique. In this case, the AML is separated from the annulus and is incised in the center. The anterior and posterior commissures are incised and the papillary muscles are split. Excessive cuspal tissue and fibrous and calcific nodules are excised. The two chordal segments thus created are sutured to the respective anterolateral and posteromedial commissures. The PML is incised in the center and the prosthetic valve is sutured in a position plicating the PML and including the AML and chordae in valve sutures. This can be visualized here. In this technique, there is an incision that is made in the PML, and we take the valve sutures. While taking the valve sutures, we are plicating the PML. The advantages of this procedure are it is simple, there is no left ventricular outflow tract obstruction. It is suitable for patients with rheumatic mitral valve disease and thickened and deformed calcific cusps. It allows for placement of a larger prosthesis, and the use of a low-profile prosthesis further reduces the incidence of leaflet obstruction from retained chordae. Coming on to the sixth technique, the Rose and O's technique. The AML is stressed posteriorly and its central portion is excised. The rim of the remaining leaflet tissue contains the marginal chordae. The defect in the AML is then closed with a running suture placed parallel to the annulus. This stacks the marginal chordae to the fibrous trigones and displaces the anterior leaflet chordae to the periphery of the mitral orifice. The valve sutures are placed to reinforce the previously running suture line. The prosthetic valve is sutured to orient the leaflets perpendicular to the native annulus. This can be seen here. The advantages include there is a reduced bulk of the AML, which reduces the possibility of impaired valve function. There is a low risk of left ventricular outflow tract obstruction, and there is a reduced risk of thrombosis on the redundant because of the redundant leaflet tissues. Some miscellaneous techniques that have been described include the Vander-Salms technique and the Hughes technique. So what are the advantages of the chordal preservation? First, it preserves the left ventricular geometry and the function. It reduces the left ventricular dilatation. There is a reduced incidence of low cardiac output in the post-operative period. There is improved short and long-term survival. There is reduced risk of LV rupture. Also, there is a reduced risk of atrioventricular groove rupture, and there is improved RV, right ventricular function. The disadvantages include obviously it increases the operative time. There is increased risks of left ventricular outflow tract obstruction in some of the techniques that had been described earlier. A smaller size of prosthetic valve might be implanted because of chordal preservation. It can cause prosthetic valve dysfunction, and it requires expertise. So coming on to the conclusion, the chordal preservation during mitral valve replacement confers several advantages as compared to the conventional mitral valve replacement where there is no preservation of any chordae. It preserves the left ventricular geometry and function, reduces the operative mortality, improves early and long-term survival, and reduces the risk of ventricular rupture. With appropriate surgical techniques, even larger size prosthetic valves can be implanted, and the risk of prosthetic valve dysfunction and left ventricular outflow tract obstruction can be eliminated. There is emerging evidence that suggests that right ventricular function may improve significantly after left ventricular chordal preservation. Thank you.